Atropine and scopolamine have similar pharmacologic effects. Which of the following actions do they share? Atropine and scopolamine have similar pharmacologic effects. Which of the following actions do they share? 1. Reduction of salivation. 2. Prevention of cardiac slowing during general anesthesia. Central nervous system depression. Mydriasis. Cycloplegia. Answers are mydriasis, cycloplegia, reduction of salivation, and the prevention of cardiac slowing during general anesthesia. The cholinergic blocking or anticholinergic drugs competitively inhibit the action of acetylcholine at parasympathetic postganglionic neuroeffector sites. So they inhibit the acetylcholine at the parasympathetic postganglionic neuroeffector sites. The principal drugs in this category are atropine and scopolamine. These are cholinergic blockers or anticholinergic, which are useful in dentistry as agents to control salivary secretion and as pre-anesthetic medication. The desirable clinical effects of the anticholinergics are mydriasis, antispasmodic actions, and reduction of gastric and salivary secretions. The pharmacology actions of atropine and scopolamine are similar in many aspects. Atropine, in the usual dose used in dentistry, does not show central nervous system response. Scopolamine, however, has a depressant effect of the central nervous system, which accounts for its usefulness as a pre-anesthetic agent and perhaps its use in motion sickness in several over-the-counter preparations. Both drugs will reduce salivary flow and in large doses block the cardiac slowing effect of the vagus nerve. Anticholinergic drugs should be used with considerable caution in patients with cardiovascular disease and are contraindicated in patients with glaucoma, prostate hypertrophy, and intestinal obstruction. Side effects are common with the anticholinergic drugs and include blurred vision, tachycardia, urinary retention, constipation, decreased salivation, sweating, and dry skin. Atropine and scopolamine are also extremely useful in therapy and examination of the eye. These drugs produce dilation, mydriasis, and paralysis of accommodation for distance, vision, and light, which is cycloplegia. Such effects are generally long-lasting and can be manifested by larger systemic doses of the drugs. Anyone scheduled for general anesthesia should have a chest X-ray, and patients over 40 years old should also have an EKG, MRI, Panorex, or biopsy. EKG. Routine admission tests, a complete blood count that includes an evaluation of the hemoglobin and hematocrit indices, a total white blood cell count with a differential count, and a gross microscopic urinalysis. Anyone scheduled for general anesthesia should have a chest x-ray, and patients over 40 years old should also have an electrocardiogram. Factors to be considered in the decision to hospitalize a patient for an elective procedure: medical problems compromising treatment, like diabetes or hemophilia, difficulty and extent of the surgery. These are the factors to be considered in the decision to hospitalize a patient for an elective procedure. Consideration of the individual patient, if it's an emotionally disturbed patient or handicapped, and the cost of hospitalization. An orofacial infection can reach the cavernous sinus through two routes. An anterior route through two routes. An anterior route via and a posterior route via the. Okay, orofacial infection can reach the cavernous sinus through two routes. It has to be vein. Okay, it's gotta be superior, so it could be either transverse facial vein and the pterygoid plexus of the veins, and as an orofacial, the last one, angular inferior ophthalmic veins, transverse facial vein, pterygoid plexus of veins. Yes. So, cavernous sinus thrombosis is an uncommon but potentially lethal extension of a odontogenic infection. Valveless veins in the head and neck allow retrograde flow of infection from the face to the sinus. The pterygoid plexus of veins and angular and ophthalmic veins may contribute to retrograde flow. Note: canine space infections and deep temporal space infections can result in cavernous sinus thrombosis via the ophthalmic veins. The first clinical sign of cavernous thrombosis include vascular congestion in periorbital, scleral, and retinal veins. Other clinical signs include periorbital edema, proptosis, which is exophthalmos, thrombosis of the retinal vein, ptosis, dilated pupils, absent coronal reflex, and supraorbital sensory deficits. The infection is life-threatening and requires prompt and aggressive treatment consistent of elimination of the source of infection, drainage, parenteral antibiotic therapy, and neurosurgical consultation. Remember the cranial nerves 3, 4, and 5. And in 5, think of the ophthalmic division of number 5. And 6. These nerves pass through the cavernous sinus. Differences between cellulitis and an abscess. Characteristics, the duration. In cellulitis, it's an acute. In abscess, it's chronic. Pain in cellulitis is severe and generalized. Abscess is localized. The size, obviously, in cellulitis is large, abscess small. The localization has diffuse borders in cellulitis, whereas abscess, they are well circumscribed. The palpation in cellulitis is doughy to indurated, and the abscess is fluctuant. Presence of pus, no pus in cellulitis. Where there is pus in the abscess. The degree of the seriousness, cellulitis is more serious than an abscess. And the bacteria that you're going to find in cellulitis are aerobic, and the bacteria in an abscess are anaerobic. Incision for drainage in an area of acute infection should only be performed after. Again, incision for drainage in an area of acute infection should only be performed after a culture for antibiotic sensitivity has been performed, after the localization of the infection, after the sinus tract is formed, or after the patient's fever has cleared up. Localization of the infection. Physiologically, it is at this time that nature has constructed a barrier around the abscess, walling it off from the circulation and making it possible to palpate the presence of purulent material within the abscess cavity, known as fluctuans. The important components in treatment of odontogenic infection are determining the severity of the infection, determining whether the infection is at the cellulitis or abscess stage, evaluating the stage of the patient's host defense mechanisms. Compromised host defenses include severe diabetes, alcoholism, malnutrition, uremia, leukemia, malignant tumors, lymphoma, or someone on cancer, chemotherapeutic, or immunosuppressive agents. These are the evaluation of the state of the patient's host defense mechanisms will involve. So these are going to be compromised host defenses. Include severe diabetes, alcoholism, malnutrition, uremia, leukemia, and malignant tumors, lymphoma, and someone on cancer, chemotherapeutic, or immunosuppressive agents. Determine whether patients should be treated by a general dentist or an oral surgeon. Criteria for referral to an oral surgeon include rapidly progressive infection, difficulty in breathing or swallowing, facial space involvement, elevated temperature, severe jaw trismus, toxic appearance, or compromised host defenses. These are important components of the treatment of an odontogenic infection. Treat, Treating the infection surgically. Removal of the source of infection and drainage of purulence. Methods of drainage of odontogenic infections. Endodontic treatment, extraction of the offending tooth, or incision and drainage of the soft tissue. These are three methods. Methods of draining of odontogenic infections, endodontic treatment, extraction of the offending tooth, or incision and drainage of the soft tissue. Support the patient medically. Airway maintenance, rehydration, analgesia, and nutrition. These are important components in the treatment of odontogenic infections, all of these that I'm reading. Again, support the patient medically, airway maintenance, rehydration, analgesia, and nutrition. Prescribe appropriate antibiotics. Infections for the use of antibiotics include rapidly progressive swelling, diffuse swelling, compromised host defenses, involvement of facial spaces, severe pericornitis, and osteomyelitis. Penicillin VK is often the preferred drug. If the patient is penicillin allergic, use clindamycin. Surgical principles of incisions and drainage. Before incision, obtain fluid for culture. Incise the abscess in healthy skin or mucosa and in cosmetically or functional acceptable place using blunt dissection and thorough exploration of the involved space. Use one-way drains in intraoral abscesses. Use thorough drainage in extraoral cases. Remove the drain gradually from deep sites. For odontogenic infections, the most common organisms are aerobic positive gram-positive cocci, anaerobic gram-positive cocci. For odontogenic infections, the most common organisms are aerobic and anaerobic gram-positive cocci and aerobic gram-negative rods for odontogenic infections. The Streptococcus species, which are highly virulent and aerobic, initiate the infectious process. Acellulitis then occurs, followed by proliferation of anaerobic organisms. Which of the following techniques is best for a wide-based frenectomy? Diamond excision, VY advancement, or Z-plasty? I believe Z-plasty. No, it's a VY advancement. When a frenum is positioned in such a way as to interfere with the normal alignment of teeth or result in pulling away of the gingiva from the tooth surface causing recession, it is often removed using a surgical process known as frenectomy. 3 surgical techniques used for frenectomy are diamond excision, Z-plasty, VY advancement. The diamond excision and Z-plasty are effective when the mucosal and fibrous tissue band is relatively narrow. These techniques relax the pull of the frenum. But a VY advancement is often preferred when the frenal attachment has a wide base. This technique is good for lengthening tissue and usually results in less scarring. Local anesthetic infiltration is usually sufficient for surgical treatment of frenal attachments. Care must be taken to avoid excessive infiltration directly in the frenum area, since it may obscure the anatomy that must be visualized at the time of excision. excessive infiltration. A sedative dose of a barbiturate should be expected to produce respiratory depression, minor analgesia, decreased BMR, all of the above or none of the above. None of the above. Properties of barbiturates. Central nervous system depressants. Central nervous system depression with barbiturates is additive with alcohol and opioids. Have no significant analgesic effects even at doses that produce general anesthesia. Have anticonvulsant effects. Mechanism of action of barbiturates. Barbiturates inhibit the polarization of neurons by binding to GABA receptors, which enhances the transmission of chloride ions. So GABA receptors will be bound by barbiturates. Characteristics of barbiturates. They are well absorbed orally, distributed widely throughout the body, metabolized in the liver to initiate inactive metabolites that are excreted in the urine. So it is secreted in the urine, it's turned into an inactive metabolite by the liver, and is well absorbed orally and distributed widely throughout the body. Therapeutic uses of barbiturates: anesthesia, anticonvulsant, and anxiety. An anesthesia influenced by direction of action. Thiopental is an ultra-short-acting barbiturate used IV to induce surgical anesthesia. Note, after IV administration, the last tissue to become saturated as a result of redistribution is fat, as compared to liver, brain, and muscle tissue. The anticonvulsant use of barbiturates. Phenobarbital used in long-term management of tonic-clonic seizures, status epilepticus, and eclampsia, and anxiety, because it can be used as a mild sedative to relative anxiety and insomnia. Now, what are the drug interactions of barbiturates? Central nervous system depressants, alcohol and opioid analgesics enhance the central nervous system depression of barbiturates. Important: barbiturates can lead to excessive sedation and cause anesthesia, coma, and even death. Barbiturate overdoses may often occur because the effective dose of the drug is not too far away from the lethal dose. This is known as a small therapeutic window. So, a small therapeutic window means that the effective dose of the drug is not very far from the lethal dose. That's a small therapeutic window. The barbiturates can produce fetal damage when administered to pregnant women. I'm going to read one more card. All of the following are true statements concerning the principles of suturing technique except one. Which one is the exception? Again, all of the following are the true are true statements concerning the principles of suturing technique except one. Which one is the exception? The needle should be perpendicular when it enters the tissue. Sutures should be placed at an equal distance from the wound margin, 2 to 3 millimeters, and at equal depths. Sutures should be placed from mobile tissue to thick tissue. Sutures should be placed from thin tissue to thick tissue. Sutures should not be over tightened. Tissues should be closed under tension. Sutures should be 2 to 3 millimeters apart. So the tissues should not be closed under tension. This is false. Sutures should not be over tightened or closed under tension. The interrupted suture is the most common suture method. Because each suture is independent, this procedure offers strength and flexibility in placement. Due to this advantage, if one suture is lost or becomes loose, the integrity of the remaining sutures is not compromised. The major disadvantage is the time required for placement of this pattern of sutures. Advantages of a continuous pattern or method is in the second figure. Ease and speed of placement, distribution of tension over the whole suture line, a more watertight closure than the interrupted pattern or method. So the question was, all of the following are true statements concerning the principle of suturing technique except one. So we already know that it should not be over tightened, so all the rest are true. And these are that the needle should be perpendicular when it enters the tissue. Sutures should be placed at an equal distance from the wound margin, 2 to 3 millimeters, and at equal depths. The sutures should be placed from mobile tissue to thick tissue. Sutures should be placed from thin tissue to thick tissue. Tissues should be closed under tension, and sutures should be 2 to 3 millimeters apart. Okay, we'll do one more to make it to 30 minutes. What areas are impacted maxillary third molars occasionally displaced into? Select all that apply. The canine space, no. Pterygomaxillary space. Infratemporal space. Pharyngeal space, or the maxillary sinus. Maxillary sinus and the infratemporal. Yes, impacted maxillary third molars are occasionally displaced into two areas. Maxillary sinus, which is the antrum, from which they are removed by a Caldwell look approach. The infratemporal space. During elevation of the tooth, the elevator may force the tooth posteriorly through the periosteum into the infratemporal fossa. If access and light are good, the tooth may be retrieved with a hemostat. If the tooth is not retrieved after a short amount of time, the area should be closed. The patient should be informed that the tooth has been displaced and will be removed by an oral surgeon who will use a special technique to remove it. Note, to minimize the chance of dislodging an impacted maxillary third molar into the infratemporal fossa during its surgical removal, Develop Number one, develop a full thickness mucoperiosteal flap. Bring the incision anterior to the second molar. Add a releasing incision if necessary to improve visualization of the impacted tooth. And number two, place a broad retractor distal to the molar while elevating it, like in Minnesota. Remember, when performing a surgical removal of a mandibular molar, do not section through the entire tooth. The lingual plate is often thin, and complete sectioning may perforate the plate and injure the lingual nerve. The interior alveolar nerve most often lies buccal and slightly apical to the roots of the mandibular third molar. Buccal to lingual movement is not efficient when removing posterior and mandibular posterior teeth because mandibular bone is too dense and does not expand in a similar fashion to that of maxillary bone.